Welcome back to Long COVID Doctor, an educational series for Long COVID sufferers. I'm Dr. Tim Robinson, formerly a family doctor, GP for 30 years, now working in Long COVID Services for 5 years. I post on podcast channels and YouTube. Hope you find them helpful. If you do, click subscribe, spread the word. Thanks for any feedback, apologies, no replies, no time. I read them though, I appreciate them. Keep them coming, they help me with my future postings. Another apology, my usual disclaimer, it's important. Any advice or treatment I mention should only be considered after talking to your own doctor. So here we are. This is the update on pain in long COVID. So, as we all know, and certainly in the patients I've seen over those 5 years in my long COVID clinics, basically pain in long COVID is very common. And pain comes in all shapes and sizes, and it could be headaches that patients are complaining of, or chest pains, or abdominal pain, or sore throats. But commonest by far is the pain that people experience in their muscles and their joints. So, this podcast, I will concentrate on muscle and joint pains. I have other podcasts on headache and chest pain if you would like to have a look. I've decided to divide the talk up into 2 parts to make it less overwhelming, less tiring. In part 1, I will cover the symptoms that patients are presenting to us, the pains, where they are, what they are, etc., what they're experiencing, and also the causes of the muscle and joint pains. In part 2, I will cover the treatments and strategies to help. So here we go. Muscle and joint pain in long COVID. What are our patients experiencing? Well, let's take them each in turn. So first of all, muscle pain. Patients come to us and sort of describe all sorts of pains in their muscles. They're individual pains, they're usually random, scattered, no pattern. They can be occurring in sort of small areas or large areas, or even big muscle groups like the thighs, for example. It also occurs in the back, upper or lower back, but particularly the upper back in sort of a distribution of trigger points. The pain is described as either tenderness, an achiness, a bruised sensation, a throbbing. It's classically worse, this muscle pain is classically worse with stretching of those muscles, bending the legs and bending the hips. So that consequently reduces the range of movement around those joints. So, moving on from muscle to joints, joint pain, again, a whole sort of selection of presentations. Patients describe a sharpness of pains, or a burning, or a hot sort of feeling in their joints. They may have some swelling. They may have sort of a tenderness when that joint is touched or moved. So consequently, they don't want to move their joints. So therefore, consequently, they'll have a reduced range of movement. Sometimes patients describe a sort of a stiffness in their joints first thing in the morning. And it takes some time for the joint to get moving, to get going, and to regain its full range of movement. The joint pains can either be sort of individual joints, or it can be sort of groups of joints. So, say the fingers or wrists or both elbows. Or, as I said, it could be individual joints. So just complaining of one particular joint, say the knee joint. The pain itself is either sort of continuous, or it's a sort of coming and going. It relapses and remissions. Or it could be sort of a low grade continuous discomfort, which from time to time flares up and breaks through and then troubles the patient more than during that sort of low grade level of pain. There may be associated symptoms such as fatigue or sort of sleep problems or any of the other long COVID symptoms. So these all are very, very common presenting symptoms of our patients for both muscle and joint pains. So what happens then? Say you have your long COVID and you are troubled with your muscle or joint pain. What do? Well, if it's significant, you're probably going to want to, and you should, seek the opinion of your GP. That's what one should do anyway, with anything that's impacting you, any symptom that is new, you've not had before. You need to report it to your doctor because we want to know what is behind that new symptom. And as I said before in other podcasts, we want to make sure that what we're dealing with is the long COVID complication, long COVID symptom, rather than something else. We mustn't be what we call COVID blind, or because you've had COVID now, long COVID. It doesn't necessarily mean that the symptom that you're now presenting with is because of the long COVID. It might be there out of coincidence. So we need to make sure that what we're dealing with is exactly that. The symptom, in this case, pain, the joints or the muscles, due to long COVID. It's safety first. We want to know, as I say, be confident as what we're dealing with. So when you go to the doctor, what will happen? So basically the GP will ask all about the symptom, what you're experiencing, the pain in the muscles or the joints, and those features that make the pain better, make the pain worse. And so all those features that I've sort of gone through with regard to the nature of that pain. They'll also want to know some, for example, the past medical history, whether there are any other illnesses in the past that might have a bearing on that pain that you have. That then will lead on to examination. The doctor will want to examine that painful part and probably and hopefully want to do a general examination as well, looking for, any sort of actual exquisite tenderness of a joint, any sort of fluid on a joint, any redness. But as I say, the general overview of the musculoskeletal system. You're looking for the range of movement of those joints. Reduced range of movement, typically, if there's pain, your range of movement is usually reduced to a degree. But equally, maybe an increased range of movement with a condition such as a sort of hypermobility. I'll come on to that a bit later on. Having done the history and examination, found the past medical history, then the doctor will probably want to do some tests, so some blood tests, for example, just a sort of standard routine blood panel. So looking at the white cells, the red cells, liver function test, kidney test, as well as a couple of others that are relevant to pain. So the C-reactive protein, for example, CRP, which is a marker of inflammation in the body somewhere, either generally or locally. So the CRP. The doctor will probably, if it's a localized joint that is inflamed and swollen, will probably want to ask for a blood test called the rheumatoid factor to see whether there's a sort of an underlying rheumatoid feature there. Equally, whilst requesting that, you probably also want to do a blood test called the ANA, anti-nuclear antibody test, for connective tissue disorders. Other investigation could be, just thinking I've used the illustration of the knee, so you've got a single localized pain over one individual joint. You may want to x-ray it. So an x-ray of, say, the knee joint or what have you. Having been through that process and sort of begun to form a list of what we call differential diagnoses in his or her mind, the GP will want to also at the same time sort of rule out any symptoms that could be sort of labelled as red flag, i.e. symptoms that are suggestive of conditions that are more worrisome. Okay, that could be indicative of a condition which needs referral straight to the hospital specialists. Thinking hospital specialists, the history examination may well have led the GP to the conclusion that actually, say, the joint pain is so severe, so impacting so greatly on the patient, then she may want to refer you straight on to a rheumatologist to have the joints investigated. Likewise, neurology might be another referral. Say there's a weakness that's sort of out of the ordinary and associated maybe with some pins and needles or numbness, then a GP would probably want to refer you to a neurologist for nerve conduction studies and electromyography, looking at the sort of the muscle function as well as the nerve function. Having been through all that process, the GPs, as I say, come to some conclusions as to what the most likely diagnosis is and ruled out other diagnoses, and then that will have led to the formulation of a sort of way to manage it. But essentially, the most important thing is, having been through that process, the GP is now confident that the pain is, in actual fact, to do with your long COVID, not something else. Like I said, not coincidental, because in a way, she has ruled out, he's not been COVID blind. Yeah, there is an association here, and it's nothing to do with anything else. So, those are the symptoms, what our patients are telling us, and the process in which the GP will go through in order to confirm that diagnosis of long COVID pain in the muscle and the joints. Which then brings me to the next section that I want to talk about, and that is the causes of that muscle and joint pain. Basically, it comes down to three sort of areas to focus on with regard to inflammation. Those are the sort of common causes for this muscle and joint pain. So the first is inflammation of the muscles and joints themselves. The second is inflammation of the nerves that pick up that inflamed area and then transmit that nerve impulses about pain to the pain center in the brain. And the third is inflammation and dysfunction of the pain center in the brain. So, first is the inflammation of the tissues, the muscles and joints themselves, the area that the patient is getting the pain in. When we think back to the whole sort of the sequence of events, what's happened? Basically, you've had acute COVID, the acute viral infection. Then that has brought you a number of different symptoms. And if those symptoms haven't settled down within 3 months, then you've actually can be diagnosed with long COVID. And with regard to the effects of the virus. So basically, they have created inflammatory process, an infective inflammatory process, which has resulted in those inflammatory mediators, those cytokines, as well as activation of the mast cells, as well as dysfunction of the immune system and creation of autoantibodies. That is, antibodies that attack your own self. The net effect of all those processes is an inflammatory response. That is, an action taken against the invading virus. And with that inflammation being set up, that leads to activation of the pain receptors, what we call the nociceptors in the tissues. And those pain receptors then send off impulses, messages to the pain center in the brain, specifically in the brain stem. And then, lo and behold, you register pain. Now, as I said, inflammation in the muscles and the joints that lead to pain is very common. And specifically in muscles, the reason why it's so common in muscles is because muscles contain a ton of ACE2 receptors. These are the receptors, if you remember, these are the receptors that the SARS-CoV-2 virus, the COVID virus, locks onto and basically infects the cells with. Okay? So muscles have a ton of these ACE2 inhibitors. So therefore, that means there's going to be a lot of inflammation. Therefore, there's going to be a lot of pain. It makes sense. The other finding is that within muscle cells, we have, through muscle biopsies that have been done, we've discovered that there are proteins, abnormal proteins called amyloid proteins, deposited in the muscle cells. Unfortunately, those amyloid proteins are pro-inflammatory. They encourage more inflammation. So that is an additional, if you like, an additional reason for an explanation behind the inflammation in the muscles. So you've got yet more inflammation and then therefore yet more pain. And then the third problem that happens with having had the acute viral infection is that the virus can also basically destroy, damage the muscle cells themselves. Therefore, you have less muscle cells and therefore you have less mitochondria, the energy factories within cells. If you've got less mitochondria, you've got less energy generation, less production of ATP. If you've got less ATP, therefore you basically can't create that energy, and that leads to anaerobic respiration. Anaerobic respiration is basically creation of energy inefficiently without oxygen, and that leads to lactic acid. Lactic acid, when it builds up, and you probably experienced this yourselves before having COVID, and you've gone for a run and your legs begin to ache and you get fatigue, and that's because of build-up of lactic acid. Well, with the muscle cells being damaged and destroyed, therefore there's less mitochondria, therefore there's more lactic accumulating, therefore there's more pain in your muscles. So those are the reasons why muscles particularly are very much subject to pain in long COVID. Turning now to joints, again, joints can become inflamed in their own right because those cytokines come in and the mast cells, etc. They cause inflammation of the tissues in the joints themselves. The joint lining, the synovial lining, as well as the cartilages. But the other problem is this creation of autoantibodies, which I mentioned a little bit earlier. So autoantibodies have been detected in patients with long COVID. And there are, to date, about 200 different antibodies, autoantibodies that have been detected. Unfortunately, one of those 200 is an antibody to connective tissues, of which there are a number. So lots of autoantibodies, different species. And the ones that are going to bring us problems to the joints are the ones to the collagen tissues, to the cartilage tissues, to the protein tissues of the ligaments and the tendons, all the tissues related to joints. Plus, also, that makes us thinking of autoantibodies, makes us think of other autoimmune conditions, such as rheumatoid arthritis or SLE or Sjögren's or scleroderma. These conditions are commoner in patients with long COVID because the body already has a tendency towards autoimmunity, so making autoantibodies. So in a way, it's a predisposition to additional problems. And often we do see in our clinics patients who actually have these other conditions, these autoimmune conditions. And so it's not uncommon presentation with our patients that actually they have these other conditions which are of the same sort of bracket, the autoimmune bracket. So basically, those are the main underlying causes for the inflammation of the tissues themselves, the muscles and the joints that go towards and are probably the major contributor to long COVID muscle and joint pain. Then let's move on to the second group that I talked about, inflammation of the nerves, the peripheral nerves, the nerves out, around the body, down the arms, down the legs, that can be damaged or not working as they should be. So the small fibers, basically we have small nerve fibers throughout the body. So we have basically there are a couple of different groups. There is the A fibers and the C fibers. The A fibers are the myelinated fast action fibers. There are the C fibers. They're the unmyelinated slow nerve fibers. These small fibers can be picked off by the acute COVID process and then therefore contributes to the long COVID symptoms. So in the tissues, if those fibers have been picked off, you've then got that then results in small fiber neuropathy. And this is extremely common in long COVID. And so basically those small fibers don't function as they should do. Therefore, they misread and fire off when they shouldn't do. So they are sort of then going to become activated and then send pain impulses from where they are. Along with that, the vagus nerve. The vagus nerve is basically there are two halves, the vagus nerve. There's the motor half and the sensory half. The motor half is basically sending impulses from the brain down to action various what we call autonomic functions. So automatic functions. But that the other half of it is the sensory half, which basically collects and transmits impulses from around the body up to the brain. The vagus nerve has chemoreceptors at its tips, at its furthest extremities around the whole body, which detect inflammation. When they detect inflammation, they then send impulses up, basically from the periphery up towards the brain, into the brain stem, where it activates and links with the pain center. So basically, you're getting lots of impulses to do with the sensory nerves coming in and sending impulses to the pain center in the hindbrain, in the brainstem. The net effect is that you register pain. So that's the second of the reasons and causes behind pain in long COVID, pain, joint and muscle pain. The third is inflammation and dysfunction in the brain center, the pain center in the brain stem itself. Okay. Again, going back to the start, what happens? You get the virus infection. Then that is taken into the body and circulates and causes its many effects, but the majority effect is inflammation, and particularly inflammation of the blood vessels, endotheliitis. Unfortunately, no blood vessels are exempt from this, and the blood-brain barrier, which is made up of a whole network mesh of blood vessels around the brain and protects the brain. If you like, it's the castle wall that protects the brain, isolates the brain from the fluids of the whole of the body. That blood-brain barrier can be disrupted and it becomes leaky, basically. So inflammatory components and cells that are in the body can then pass across that leaky barrier into the brain and bring about inflammation. Unfortunately, this is not what you want, because it ramps up the inflammation in the brain, and in two areas. One is basically throughout the brain, but the two areas that are relevant to this muscle and joint pain is the hypothalamus. If the hypothalamus is affected and becomes inflamed, etc., then that leads to dysautonomia, dysfunction of the autonomic nervous system. And the reason why this is relevant in our muscle and joint pains is because with that dysfunction of the autonomic nervous system, that leads to an increase of the sympathetic nervous system. The sympathetic nervous system brings about tension of the muscles, and muscle tone increases. And so they never relax fully. So therefore, they're always burning up energy. So therefore, then that leads to lactic acid build up also, which, as I explained earlier, is uncomfortable. There's discomfort registered in the muscles for that reason as well. So therefore, further contributory factor that brings about that muscle discomfort. The other area of the inflamed brain, which is relevant to this muscle and joint pain, is the brainstem. We can't keep talking about the brainstem. Activation of some of those nuclei in the brainstem results in the sickness behavior response, which is a natural response that we all have. Say when you get flu or a chesty cough, then the brainstem registers that and basically responds with this thing called a sickness behaviour response. And the sickness behaviour response is sort of temperatures you get, and the malaise you get, and headaches you get, along with any of those infections, flu or chest infection or what have you. Part of that sickness behaviour response is generalised pain, which could be felt anywhere. So that's going to contribute to your long COVID muscle pain. The other problem, as I've talked about in both first and second causes for inflammation in the tissues and all the nerves, is activation of the pain centre in the brainstem itself. The net effect of all this, of course, is just pain, and the way we sort of view it is actual and make it sort of easy to understand is it's sort of pain of two types, both nerve sort of pain from the tissues and pain from the nerves. So pain from the tissues, we call that nociceptive pain. Pain from the nervous tissues, we call that neuropathic pain. And we divide these up because it makes us be able to, if you like, tailor the treatment to tailor the treatment to the type of pain you've got. So it's important to be able to think of and divide the pain up into those two areas in order to direct the best management to help with the symptom, the pain. If that pain is long-lasting and persistent, then if it's still there after 3 months, it then is reclassified from acute pain to chronic pain, and we know this as, or give it the term, the title as central sensitization. So that's pain hypersensitivity. Okay. Central sensitization. Central sensitization. It's a bit of a mouthful. Central sensitization. That's so sensitizing. So hence pain hypersensitivity, which, as I say, is fixed. And the explanation behind this central sensitization is basically those pain fibers in the pain center in the brainstem become oversensitive, overexcitable. Sort of the pain threshold lowers. A condition which we give it a sort of a fancy title to, and that is hyperalgesia. The other thing that happens is that you can develop something called allodynia. So what is allodynia? Basically, allodynia is basically pain signals that are generated from non-painful stimuli. What do we mean by that? Okay, so a non-painful stimuli, such as just simple touch. In patients with central sensitization, even simple touch is really painful. They're very hypersensitive, okay? And so in other words, the nerves are misreading painless stimuli. Yeah? Painless stimuli. So it's not a painful stimuli, it's a painless stimuli, but patient is registering pain. So those nerves are like malfunctioning. They're misreading the stimulus. So the combination of allodynia, so that's basically misreading of painless stimuli, and hyperalgesia, that's overexcitable, oversensitive, hypersensitive pain, is basically what describes central sensitization. We've known about hypersensitivity or central sensitization for many, many decades. And basically, we see this in a lot of conditions of chronic pain, so that pain that is fixed and abnormal, such as in irritable bowel syndrome, fibromyalgia, migraine, and Ehlers-Danlos syndrome. I mention Ehlers-Danlos syndrome because it's a condition that is diagnosed on a number of symptoms, pain being one in joints, but also hypermobility, hyperflexibility, hyperextension of joints. So it is a genetic condition in which the collagen is not normal. Okay, so consequently, the patients with Ehlers-Danlos hypermobility can sort of get their thumb right back, or their elbow sort of hyper extends, and sort of this part of the arm, the forearm, dips right down. That is hypermobility. And we do find pain, central sensitization in Ehlers-Danlos. We do find that there are a group of patients in our long COVID population who do have hypermobility, and with it goes all the pain. So it is something that, if you like, it could be a risk factor, viewed as a risk factor for long COVID, and it's a bit of a sort of a tendency it's a tendency for someone to develop long COVID. So, I've talked a lot about the causes of long COVID muscle and joint pain, and I've gone into quite a lot of depth and detail for a number of reasons, but the most important reasons are that it's to upskill you so you can understand your condition, so you have a knowledge, and in a way that helps for your own validation of your condition. These causes have an explanation. Your symptoms have an explanation behind them, and what I've said is all research evidence based. It's not imagined. Your symptoms are not imagined. They're not in your head, okay? And this is important because it actually helps acceptance of the condition. It brings peace of mind. And it's also helpful for us to be able to manage the condition, and for you to be able to self-manage as well. So, those are the reasons why I think that it's really important that, you have a full understanding of your symptom and the causes behind it and have led to those symptoms. So there we are. That's the first part of my talk on long COVID muscle and joint pain, what our patients are experiencing, and the causes, as I've said. Part 2, I'll talk about how we're going to tackle them. How are we going to tackle this joint and muscle pain? So the treatments and the strategies. So there we are. I hope you found that helpful. So I'll see you there.